Welcome everybody. Thanks for joining us today. This is the 11th in our Centre for Academic Primary Care webinar series. I'm Helen Bolton and I'm the Communications Officer at the Centre for Academic Primary Care. And our speakers today are Nicola Wiles, who is Professor of Epidemiology at the Centre for Academic Mental Health at the University of Bristol, Dr. Charlotte Archer, who's a Research Fellow at the Centre for Academic Mental Health and the Centre for Academic Primary Care, and Dr. Daniela Strelchuk, who is a Senior Research Associate in Primary Care Mental Health, also at the University of Bristol. So just before I hand over to Nicola, who's going to get us started, just a few housekeeping points. This webinar is being recorded and we'll be making it available on our YouTube channel within a couple of weeks after the webinar. For the duration, you will be muted and your video will be off. Each of our speakers is going to take questions after their individual presentations. So please do use the chat to post your questions either during the presentations or after during the Q&A sessions. Okay, that's it. So over to you now, Nicola.
Thanks, Helen. That's great. So welcome everyone, and in the next roughly hour or so, what we want to do really is just to talk a little bit about the work that's taking place in Bristol in terms of looking at novel interventions for people with common mental health conditions. Get the slides going. So first of all, I'm going to talk about the ID study, which is a new multi-centre trial, which is going to be looking at the efficacy of a trauma-focused intervention, EMDR, for people with depression. Then I'll hand over to Daniela, who'll talk through her work, her fellowship work, which is looking at developing a guided self-help version of EMDR for people with post-traumatic stress disorder in primary care. And then finally, I'll pass over to Charlotte, who will talk about her work looking at the use of beta blockers for anxiety. So as many of you will already know, depression, anxiety and post-traumatic stress disorder, or PTSD, are common conditions in primary care with a prevalence of around 10% approximately. But what we also know is that only around 50% of people with anxiety and depression will respond to the most common treatments. And by that, we mean antidepressant medication or talking therapies such as cognitive behavioural therapy or CBT. And similarly, there are effective trauma-focused interventions for PTSD, but access is often limited to secondary care. And so what we really need is to think about novel approaches to treating these common conditions, and particularly perhaps where there are different mechanisms from existing treatments. So EMDR, or eye movement desensitization and reprocessing therapy, is a nice recommended trauma-focused psychological intervention for people with PTSD. But more recently, that protocol was adapted by Arne Hoffmann and colleagues in Germany for treating depression. And the focus really with that new protocol is about eliciting and reprocessing dysfunctionally stored or what might be referred to as pathogenic memories that have been both implicated in being predisposing to and also maintaining depression. And many people with depression talk about distressing past events in their lives that they link to their depression. And so these stressful life events, and by that we mean things like job losses, bereavements, as well as traumatic experiences, so the larger traumas such as abuse, neglect or accidents, have been associated with both an increased risk of depression and also poorer prognosis. And targeting memories linked to depression using this therapy provides us with a new avenue for treatment, and also actually aligns with NICE guidance, which focuses on discussing stressful experiences in the initial primary care consultation. And as you can see from this meta-analysis at the bottom of the slide here that was published in 2021, there's some evidence from small studies that EMDR may reduce depressive symptoms. But they are very small studies, only a maximum of 80 participants in the largest of these studies, and are generally low quality and there's substantial heterogeneity. And so currently there's no definitive evidence of efficacy of EMDR as a treatment for depression from large randomised controlled trials. Some of the skepticism that perhaps exists also around EMDR relates to the fact that we don't really understand how this therapy works. And whilst cognitive behavioural therapy, or CBT, focuses on teaching people skills to change unhelpful thoughts and behaviours, EMDR really focuses on reprocessing these dysfunctional or pathogenic memories to try and reduce the emotional salience and enable more positive beliefs and behaviours to emerge over time. And there's the adaptive information processing model, or AIP model, that underpins EMDR. And that is based on there being an innate system that processes memories in an adaptive way, so that the emotional salience of a memory, an upsetting memory, usually decreases with time. So what normally happens is if there's an upsetting event, or a life event, that memory is stored as a sensory representation, very much an emotional memory. But then over time, as the upsetting memory is processed, it brings in contextual information. So the event's over, other people say it's not my fault, and then that memory becomes stored as a contextual representation, or a factual memory, and then can be recalled without the distress and physiological arousal that was associated with that original upsetting event. However, what happens when there's an inadequate shift from that sensory representation to the contextual representation is what's thought to result in these pathogenic or dysfunctional memories. And recall of these pathogenic memories isn't under voluntary control and can be triggered by internal or external stimuli, which then result in a re-experiencing of those cognitive, emotional, and physical states that were associated with that very original life event. And it's proposed that depression can both arise and also be maintained by the stimuli that trigger these pathogenic memories. It's really the wrong way. And so the working memory hypothesis is really the leading theory of how EMDR enables this shift from emotional to factual memory. And there is some empirical support that comes from small experimental studies. There's no large-scale studies have looked at the mechanism of this working memory hypothesis as part of the trials that have been conducted to date. And a central element of this EMDR is the bilateral stimulation, or the dual task. And so during therapy, people are asked to make eye movements whilst they recall that memory, usually either by following the therapist's finger, as you can see in the picture here, or following a light on a light bar, or possibly using tapping mechanisms. And the idea is that the dual task demand on working memory then limits the scope for emotional overactivation that can impair that memory processing. And so it's hypothesized that as the processing occurs, the vividness and the emotional intensity of the memories decreases, and global self-beliefs become more positive, and that in turn, this leads to symptom reduction. But as I said, no studies of EMDR for depression have looked at changes in these factors as mediators of the treatment effect, and also haven't looked at whether working memory capacity affects treatment response. So the ID trial, or EMDR for depression trial, is looking to understand the efficacy of EMDR given in addition to usual GP care in improving depressive symptoms in primary care patients with depression compared to usual care alone. And there's also an embedded mechanistic study, which is looking to see whether reductions in depression are mediated via these key memory processing mechanisms, and also whether working memory capacity is associated with treatment response. In addition to the nested mechanistic study, there's also a qualitative element to the trial, which is looking at understanding patients' and therapists' views and experiences of both usual care and EMDR as treatments for depression, trying to unpick a little bit more about that mechanistic element of the study, so understanding both patients' and therapists' views on how EMDR impacts the intensity of those memories, beliefs, and symptoms that are linked to past stressful events, and also to help us understand a little bit more about the differences between EMDR for depression and EMDR for post-traumatic stress disorder. And then finally, there's also an intervention costing exercise, which will look at the estimating the cost of delivering EMDR in the NHS. So the study is set in UK primary care and will be recruiting from GP practices in 3 regions in England, so in Bristol, Exeter and in London. And I think although it's important to point out that although our recruiting centres are all in the south of England, if you map them to heat maps of regional research activity, it does show that our university centres are located in areas of unmet mental health need, which I think is important in terms of potential generalisability of our findings. So in this trial, we'll be looking to recruit patients who are aged 18 or over and who have depression, and importantly, who are willing to work on the memories of those past stressful experiences that they think are linked to their depression. The exclusion criteria for the trial are shown on the slide here. So we'll be excluding people with post-traumatic stress disorder, because we're interested obviously in looking at this as a treatment for depression, not PTSD. Excluding those who have a recent history of substance use disorder, those with severe mental illness, for example. And we were recruiting via 2 routes. So our collaborating practices will either be able to refer participants from consultations, refer them directly to the research team, and we'll be working with our collaborating practices to conduct record searches to identify potential participants. And the practices will then mail out invitations relating to the study to those potential participants. And then people who are recruited via these 2 routes will respond directly to the research team, and we'll look to telephone them initially to conduct a brief screen in terms of eligibility. And then those who are potentially eligible will then attend a longer appointment with a researcher to obtain consent and assess eligibility. And those who are eligible and consenting will be randomised in a 1-to-1 ratio, and they'll either receive usual GP care, and there's no restrictions to that, so people can continue with antidepressant medication, or they may be referred for other talking therapies, for example, or they'll be referred, randomised rather, to 12 to 18 sessions of EMDR in addition to usual care. And those sessions will usually take place weekly. There'll be in-person sessions with an accredited EMDR therapist, and each session will last between 60 to 90 minutes. Participants in the trial will be followed up 6 times over a year, so more intensively to start with. And then our primary efficacy outcome, so will be depressive symptoms on the Beck Depression Inventory, so that's a self-report measure of depression at 26 weeks post-randomisation. Secondary efficacy outcomes will include remission, so below a threshold on the BDI score, and also other measures such as anxiety and function. So we're looking to recruit 380 individuals, so a substantially large sample from our 3 centres. And initially we'll be starting with an internal pilot for 6 months, where we hope to demonstrate that we can recruit as planned and that people are engaging with the intervention. We're currently in the final stages of setup. Our therapists who are working with us here in Bristol are starting with their training cases, starting to use this EMDR protocol, and then we'll be opening to trial recruitment shortly. And hopefully our recruitment trajectory will go as the line suggests in the graph on the slide. So that's just giving you really a whistle-stop tour of the ID study. So I'd be happy to answer any questions if you'd like to just post those in the chat. Thank you. Okay, so thanks. So the first question I've got there is about how does EMDR used in the trial differ from standard EMDR? So the focus really is about the target, is my understanding. I'm not an EMDR expert, but the focus of therapy is really about what's being chosen as that target for focus during those processing sessions. So it's about drawing a symptom event map and looking back and seeing what was the pattern in terms of the person's depressive symptoms, and then looking and seeing how does that relate to life events that that person might have experienced, and then identifying the potential target in terms of that life event that the individual will be working on during therapy. Okay, and just look down. So there's a couple of questions around the severity of depression of who we're aiming to recruit. So we're looking to recruit anyone who meets ICD criteria for depression and who scores above 14 on the Beck Depression Inventory. So that's relatively mild depression. So we expect to get a range of people recruiting into this trial, both with those with mild symptoms, but also based on past experience from previous trials. Probably a substantial proportion of participants will have moderate to severe symptoms in terms of depression. Okay, sorry, just skipping around the trial. So there's another question about why the BDI has been chosen as the primary outcome over the PHQ-9. So we will be using the PHQ-9, or our therapists will be using the PHQ-9 in weekly sessions with participants. And so therefore we thought it was important to use a different measure of depression as our primary outcome, because otherwise the participants who are in the intervention arm will be repeatedly using the PHQ-9 each week, and that won't be happening in the usual care arm. And so there may become a practice effect, which may then potentially introduce bias. So that's why we're using different measures, different self-report measures as our primary outcome to that, which will be used in therapy. So another question is, do I have an idea what GPs in Bristol will be able to refer to the trial? So at the moment, we are looking for GP practices within the Bristol, North Somerset and South Gloucestershire area to collaborate with us. And that's purely on a geographical basis in terms of our therapists then coming to deliver therapy, which in Bristol will primarily take place in GP practices. So it's just literally about that travelling distance for our therapists. If you're interested in taking part, please get in touch and contact the ID team. I think my email will be at the end of this presentation, and we can talk further about that. Okay, I'll just take one final question before I hand over to Daniela. So what might be the potential risk of patients who do not get the EMDR option during randomization in terms of their expectations if they thought this therapy would be their last chance of recovery? So obviously, I think an important part of the trial is that at the moment, we don't know whether EMDR is an effective treatment option for depression. And it will be explained very clearly to potential participants that, there is a 50-50 chance of being allocated to treatment, EMDR, or to usual care. And I think it's something we've had to work with participants very carefully in previous trials, just to think and make sure that we're explaining very clearly this chance of equal randomization between the two groups, and making sure that people are fully informed that that is the option here, but also reinforcing the value of participation in that usual care group. So it's very important that we have people who continue with usual care, because without those individuals in that group, we can't compare the outcomes between EMDR and usual care. And so making sure that they understand the value of everyone taking part. Okay, thank you. So now I'd like to hand over to Daniela, and she can talk about her work on developing a guided self-help version of EMDR.
Thank you, Nicola, and hello, everyone. I'm now going to talk about my work on the development of a guided self-help EMDR intervention for people with mild to moderate PTSD in primary care services. So PTSD is a mental health illness which develops in response to a traumatic event, such as physical, sexual, or emotional abuse. The most common symptoms of PTSD are the reliving of the trauma in the form of flashbacks or nightmares, avoidance of people, places, or situations which are a reminder of the trauma, and hypervigilance. People with PTSD have a poor quality of life, and there are also high costs associated with PTSD. It is estimated that the direct and indirect costs of PTSD are around 40 billion annually. And just to give you an idea of what this figure means, I have also listed here the NHS England budget for last year. So as you can see, the direct and indirect costs of PTSD are nearly a quarter of those of the NHS. EMDR is an effective psychological treatment for PTSD, which is currently recommended by NICE guidelines. It is also important to mention that the NICE guidelines also recommends trauma-focused CBT as a first-line treatment for PTSD. In terms of the effectiveness of these interventions, EMDR and trauma-focused CBT are comparable. Now, EMDR is usually provided in person in secondary care services. And the problem with this is that there are usually long waiting lists for accessing treatment, which can sometimes exceed 1 year. And some people also have difficulties accessing treatment because of childcare responsibilities or difficulties traveling. A potential solution to this problem would be to develop a low-intensity intervention, which would be delivered as part of a stepped care model for people with a mild to moderate PTSD symptoms. And this intervention would be similar to the low-intensity interventions, which are currently available for people with depression and anxiety in the NHS talking therapies. So this intervention would take the form of a clinician-guided self-help EMDR treatment, which would have 2 elements to it. So the self-help element, which means that patients will access treatment in their own time via the use of a computer or a smartphone. And then it is the clinician-guided element, which means that patients will also occasionally meet with a therapist to discuss treatment. So the aim of my study is to prepare the ground for the development of a guided self-help EMDR intervention for people with mild to moderate PTSD symptoms in primary care. And my study has 2 phases. The first phase, which involves the development of a portfolio, which is comprised of a review of the self-help interventions and apps currently available for PTSD. And this phase has been completed. And the second phase, which involves focus groups and qualitative interviews with patients with PTSD and clinicians who are involved in the assessment and management of this patient group. And this phase is ongoing. Now, I would like to give you a very brief overview of our findings from phase 1. So we started broadly and we looked at whether there are any guided self-help interventions for PTSD. And this is a paper which has been published in the BMJ. And this paper looked at the effectiveness of a guided internet-based CBT intervention for people with mild to moderate PTSD to one traumatic event. And findings of this paper showed that the guided self-help CBT intervention was non-inferior to the in-person, face-to-face CBT. Now, you might wonder, why do we want to develop a guided self-help EMDR intervention if there is already an effective trauma-focused CBT intervention for people with PTSD? So I think it is worth mentioning that even though trauma-focused CBT and EMDR are equally effective, the way they help people process their traumatic memories is different. So unlike trauma-focused CBT, EMDR does not require people to give a detailed description of the trauma, which can be highly distressing in some people. And also, unlike trauma-focused CBT, EMDR does not require any homework. And studies on depression showed that homework can very often evoke negative memories of school. So it is possible that EMDR might be a more acceptable form of delivering treatment to people with PTSD. We have then narrowed down our search and looked at whether there are any guided self-help EMDR interventions. And even though very little has been published in this area, this is a randomized control trial which looked at the effectiveness of a self-help EMDR intervention, which was based on the principles of group EMDR. And this study showed that people who accessed this intervention had decreased depression, anxiety, and stress post-treatment, and more than 90% of the people who accessed this intervention found it helpful. We have then looked at the PTSD apps which are currently available in the UK. And this is a systematic review which looked at both CBT-based and EMDR-based apps for PTSD available in the UK. And this paper concluded that none of the EMDR apps which they have reviewed were high quality in terms of engagement, information quality, and functionality. And this is another review which looked at the EMDR apps available for PTSD in the US. And this paper concluded that none of the EMDR apps which they have evaluated were recommended for the treatment of PTSD symptoms, even though some of them could be used by clinicians. So to summarize findings of phase 1, there is limited but encouraging evidence to support the development of a guided self-help EMDR intervention for people with mild to moderate PTSD. And this first phase was important because it informed the development of the second phase, where we are conducting qualitative interviews and focus groups with people with PTSD, EMDR therapists, GPs or mental health nurses, and psychological well-being practitioners. So the aim of these interviews is to explore patients' and clinicians' views on the acceptability of this intervention, on what would make a guided self-help intervention attractive to patients. And in interviews with EMDR therapists, we are exploring in more detail how to adapt the standard EMDR intervention to a guided self-help type of intervention. So the main outcome of my study is to develop a paper prototype of the guided self-help EMDR intervention, which will then be tested as part of a feasibility study, where we are hoping to create and test the first digital prototype, which will be further refined so that at the end of the feasibility study, we will have a good version of the guided self-help EMDR intervention, which would be ready to be assessed as part of a large randomized controlled trial. Thank you very much. If people have any questions, could they please put them in the chat and I'll try to answer them. Thank you. So there's a question whether there has been a discussion about differentiating between PTSD and complex PTSD. So I think this is related to to my study. So in our study, we're looking into developing this intervention for people with mild to moderate PTSD symptoms. So people with complex PTSD will not be given access to this intervention. We do not think that this intervention would be appropriate for people with complex PTSD. So there's a question about what constitutes mild to moderate PTSD symptoms and any other exclusion criteria. So in interviews with EMDR therapists, I'm now exploring what actually constitutes mild to moderate PTSD symptoms and what should be the cutoff on the PTSD scales in order to say that someone has mild to moderate PTSD symptoms. And it has been suggested, I think, a score of 30 on the PCL-5, but that's something we are still exploring at the moment. In terms of other exclusion criteria, people who are dissociating, people with a history of self-harm, psychotic illnesses, people who are unable to self-regulate will probably not be given access to this intervention. But again, this is a work in progress. So this is something which are still exploring in interviews with clinicians. If there are no other questions, there's another question, sorry, about the exclusion of patients with a historical past substance abuse. Again, this is something which has occurred in some of the interviews I have conducted with EMDR therapists, but we do not yet have a definitive answer to this question. Thank you. So if there are no any other questions, I will then hand over to my colleague Charlotte, who will talk about her work on anxiety.
Thanks, Daniela. So now we're going to turn our attention to pharmacological interventions in primary care, this time focused on the use of beta blockers for the treatment of anxiety. So there's been much less investment into anxiety research compared with depression, despite the fact that anxiety is actually the most common mental health condition worldwide. Now, I'm just going to give you a bit of an overview of what's happening in primary care in terms of prescribing for anxiety more generally, first of all. So this graph here shows incident or new anxiolytic prescriptions for patients with anxiety between 2003 and 2018 using CPRD data. Now, CPRD is national anonymised general practice data. So we can get large data sets here. So this data set is from 2.5 million patients. And what you can see is if you focus on that blue line at the top, that's prescribing of any anxiolytic drug. And that is largely being driven by prescribing of all antidepressants, which is the red line below that. And in particular, prescribing of SSRI and other antidepressants, which is the green line. And that's what we would expect to see. You know, as Nicola mentioned at the start of this presentation, SSRIs are one of the main drugs that are used for anxiety. If you look at the orange line, you can see that prescribing of benzodiazepines declined over the 16-year period. And again, that's something that we would expect to see. There are increasing concerns around dependency and toxicity from benzodiazepines, and really they should be only used on a short-term basis anyway. But what I'd like you to focus on is that grey line there. So that is prescribing of beta blockers. And you can see that prescribing increased in the second half of that study period. Now, about half of those prescriptions were prescribed for longer than 6 months. So patients are taking them on a more medium to longer term basis. But the large caveat to all of the data that I've presented in this slide is that it's potentially capturing some prescriptions that are being issued for other indications. So for example, beta blockers can be used for hypertension, high blood pressure. And it's possible that some of these prescriptions were given to patients to treat their hypertension, even though they also happen to have anxiety. So just want to point that out at this point. So why is it interesting that we're seeing an increase in prescribing of beta blockers for anxiety? Well, beta blockers do not feature in the NICE clinical guidelines for anxiety. So at the moment, GPs don't have any guidance on when or how they should be used for anxiety. Propranolol, which is one type of beta blocker, is in the BNF, and it is licensed for use for the physical symptoms of anxiety. So things like sweating or heart palpitations or tremors. But why isn't beta blockers in the NICE clinical guidelines? Well, I suspect it's probably because to date, the evidence for beta blockers has been inconclusive. So although beta blockers are quite good at treating those physical symptoms of anxiety, they don't address the underlying cause. Also, in more recent years, the last couple of years, we've seen an increasing number of reports that have highlighted a potential under-recognized risk of toxicity in propranolol overdose, and also concerns around when the drug is prescribed alongside SSRIs. A systematic review looked at the evidence on the effectiveness of propranolol on data published up to 2014. And what that review concluded was that there was a need for more robust evidence in this area. So the question we're left with is, are beta blockers a safe and an effective treatment for anxiety? And really, the best way that we can answer that question is to conduct a large-scale randomised clinical trial. But before we can do a large trial, we really need to understand a little bit more about how beta blockers are being used in clinical practice for anxiety in primary care. So I have started to, or I've completed some of the preliminary work to try and inform how they're being used in clinical practice. And I've undertaken that work as part of a launching fellowship programme of work with 3 work streams. And I'm just going to give you a brief overview of what that work found. So the first work stream was a secondary analysis of CPRD data, which was the CPRD data I showed you a few slides ago. And essentially, all that was doing is replicating the same analysis, so investigating trends in the prescribing of beta blockers, but this time excluding treatment for all other indications. So for example, the high blood pressure. The second work stream was a systematic review looking at the effectiveness of beta blockers as an anxiety treatment, but this time extending that previous review by a further 10 years, but also including all beta blockers, so not just propranolol. And then the third work stream was a qualitative interview study with GPs to really start to understand, their views on beta blockers and on what they think to designing and potentially conducting a trial in this area. So just to give you an overview of the findings from those 3 work streams. So that first work stream, so those CPRD analyses, again, looking at incident, so new anxiolytic prescriptions for patients with anxiety between 2003 and 2018, but this time with all other possible indications excluded. And you can see this orange line here is trends that were seen in that original analysis that I presented earlier. And this grey line here is the results from the new analysis with other indications excluded. And as you can see, the incident rate for each year was slightly lower, which we would expect to see, but actually that trend of increasing prescriptions has held true. So we can be fairly confident in saying that it is an increase in prescribing for anxiety that we are seeing. The second work stream, which was a systematic review looking at the effectiveness of all beta blockers as a treatment for anxiety, including studies published up to 2024, including randomised controlled trials and crossover design trials. And I ended up including 10 papers, and they were just focused on patients with panic disorder or social anxiety. So there were no patients included there that had generalized anxiety disorder, which is the most common type of anxiety we usually see in primary care. There were a total of 179 participants, but the sample sizes range from 11 up to 85. So we're talking about quite small studies here, really. Of those 10 papers, 5 were eligible for meta-analyses, which was conducted by a comparator group using random effects models. And what I found was there was no evidence for a beneficial effect of beta blockers compared with either placebo or benzodiazepines. And again, that's just in patients with social phobia or with panic disorder. But one really important finding here to note is that all of the studies included here had either high or unclear risk of bias across multiple domains. So that's really saying, you know, that the evidence of these studies, the quality is really poor here. And the final work stream was some qualitative interviews with 17 GPs to really understand why are beta blockers prescribed for anxiety. So the findings across 3 themes, firstly linked to pragmatic prescribing. So GPs talk about beta blockers as a tool in the toolbox for use in anxiety, and the fact that they are licensed for anxiety. You know, they are mentioned in the BNF, so it is something that's available to them as an option in primary care. The second theme relates to safety-driven prescribing. So GPs talked about the fact that beta blockers were viewed as quite a low-risk drug. An example they gave in relation to this was how they might be more likely to use a beta blocker compared to an SSRI in a younger person where they might have concerns around suicidal ideation. GPs also talked about beta blockers as a potential alternative to benzodiazepines. So they said how historically, when they started a patient on an SSRI treatment, they might have also given a short-term prescription of benzodiazepines to help alleviate some of those symptoms of jitteriness that SSRIs can bring on. Now, they might be more inclined to use a beta blocker instead of a benzodiazepine. And the third theme relates to patient-driven prescribing. So GPs talked about how patients wanted a drug that gave an immediate effect and was something that wasn't mood-altering. And actually, beta blockers do work quite quickly. You know, they can help alleviate some of those physical symptoms within about a space of an hour. And they don't address those psychological causes of anxiety. You know, they aren't mood altering. They do just focus on those physical symptoms. GPs also talked about how patients wanted a patient-managed treatment. So beta blockers are a drug that can be given to be used on an as-needed basis. Patients can stop and start the medication when they want to, and there are less concerns around deprescribing or withdrawal. So actually, beta blockers give patients more control over how they want to manage their mental health. So just to sum up kind of the findings from that launching fellowship program of work. So CPRD analysis shows that we know there's been an increase in prescribing of beta blockers for anxiety. But the systematic review shows there's a lack of robust evidence of effectiveness. So we don't have any patients, any studies including patients with generalized anxiety, for example. And the third work stream, that qualitative interview study, says that actually GPs think beta blockers are quite low risk. They offer that immediate relief of symptoms, and they're quite a patient-managed drug. So what's the next steps? So I think there's some more preliminary work that needs to take place. So we need to understand the views of patients, and we need a bit more data around how these drugs are being used in terms of duration of prescribing in practice. All of that data would then be able to feed into the design of a feasibility study, which would look at whether we can conduct a full-scale trial looking at the safety and effectiveness of beta blockers as a treatment for anxiety. So really answering that question of, can we do a trial in this population with this drug? And then the longer term aim here would be to do that definitive randomised control trial to really answer those research questions around the safety and effectiveness. So I'm now going to hand over to Nicola, who is going to chair any questions that you might have around this topic. Just pop those questions in the chat, please.
Okay, thanks, Charlotte. So I think there's one I saw popped in the chat already. So there's a question that says the NICE guidance highlights the potential risk of beta blockers, in particular to individuals with asthma, COPD, and diabetes.
Yeah, so the GPs that I spoke with, they have really good insight into the contraindications for beta blockers. So yeah, absolutely, all of those conditions, they had an awareness that it was riskier to prescribe in those groups. I think what we're talking about in terms of safety really is thinking around patients that do have suicidal ideation, and making sure patients are aware that beta blockers aren't necessarily, a low risk drug, and having that conversation between the patient and the practitioner when it's first initiated.
Okay, thanks, Charlotte. And similar lines, there's a comment from Nikki who says, we know that many people are prescribed beta blockers and can indeed play a role in anxiety management, particularly where physical symptoms are troublesome. However, more information is needed, we feel, in terms of dosage and what other meds might also be needed to manage anxiety and how these could interact with, say, for example, propranolol. And ultimately, however, we would say that more anxiolytics are needed rather than anxiety being treated as part of depression via antidepressants.
Yeah, I think that's a great point. So one of the kind of unknowns at the moment is dose. So we know that there's quite a wide spectrum of doses that can be given. Patients might be prescribed a higher dose, but they actually only take a lower dose, again, because it's that kind of patient managed drug. And again, we don't know that much about the combinations of drugs that are being used for anxiety alongside beta blockers. So there's some evidence to suggest that actually we are seeing that increase in prescribing of an SSRI and propranolol. We've got some data around that. It's not it's kind of going back a few years now, but we expect that trend has continued. And I think there's probably more work that does need to be done in this area to understand how this drug is being used alongside other drugs to help people manage their mental health.
Thanks, Charlotte. And there's a couple of comments which I'll leave you to have a look at in relation to, I think, people signposting in relation to MHRA alerts as well around propranolol risks and a future prevention of death report, presumably sent to NICE. I think they're saying in 2024. There is one other question in the chat at the moment, which says, what do you think the inclusion-exclusion criteria might be for the trial? And who do you think maybe the most or least likely to benefit?
So I think inclusion and exclusion criteria is a really good question, because we're missing the patient voice in all of this at the moment. So as you'll have seen, I presented the views of practitioners, but I don't have, other than PPI work, we don't have that research that's been done with patients to really know the exact type of anxiety that patients are taking this for. We think there's been more of a move away from situational anxiety to more generalized anxiety. So probably patients that have a more chronic condition. It's still being used in situations, but there's probably been more of an increase in that generalized anxiety. So that's probably where there's a kind of a stronger research interest, because we just have less data around that. But I think probably for a trial, we'll be looking at a pragmatic inclusion criteria. So perhaps rather than trying to specify on subtype of anxiety, we might be expecting someone to reach a certain threshold on the GAD-7, for example. In terms of who I think would benefit, I think In terms of the longer term piece of work, if we're going to do this trial, I suppose it would depend on on which way the results went. So we've got the potential that we might do a trial and we would find evidence of benefit, in which case, that's great for patients, isn't it? Because we can say, actually, there's this other drug that could potentially go in the NICE guidelines that can help patients in this particular condition. This is when it should be used. Of course, a trial could go the other way and we could find no evidence of benefit. And again, I think that in some ways is also still really helpful, because it might deter some of that more harmful prescribing that we're seeing. And actually, if there is no evidence of benefit, then, that's not helping patients either. So I think it could potentially go either way.
Thanks, Charlotte. And another question just asking really about your PPIE advisory group input into this project. I think may just have got the wrong impression in terms of not having had any PPI input. I think you were talking about interviews with patients there, weren't you?
Yeah, so we've had so much PPI input, we've had so much interest, and we've got a really strong PPI panel that have been involved and have shaped the whole research programme and are kind of shaping the programme going forward. But yeah, just to be clear, what I was talking about there is we haven't done qualitative interviews with patients. We know it's needed, and we're trying to kind of get the funding to do that. But yes, have done lots of PPI work, just to make that clear.
Charlotte, and just another comment linking, I think, to the thoughts from earlier, really saying that given that anxiety disorder is the most common mental health condition, we really do need to be doing much more worldwide to identify new solutions and anxiolytics.
Yeah, absolutely. And I think, as I said at the start of the presentation, there's just been much less investment into anxiety as a mental health condition compared with some of the other conditions we see in primary care. And we really want to try and, to change that.
Charlotte, I'll just give it a minute, see if there are any final questions. Otherwise, I'd just like to really just thank everyone for joining us today, and hope you found this a useful and informative session. And I think if we just move on to the last slide, I think that should have our contact details for myself, Daniela, and Charlotte, along with our funder acknowledgements as well. So thank you very much for joining. I don't think at the moment there's any more questions.
Great, thanks, Nicola, and thanks everybody. Just before you go, I was just going to do one last slide there. Yeah, so there are a number of ways that you can keep in touch with us. As I say, this webinar is part of a series, and you can watch back recordings from previous webinars on our website at www.bristol.ac.uk/CAPC. And I'll be sending around a feedback form after the session. So it'd be great if you could fill that in for us, and that will help us improve our webinars going forward. So thank you, everyone. Thanks to the speakers, and hope to see you at a future webinar. See you soon. Thank you.